Deputy Speaker, and may I congratulate the Shadow Minister for bringing such an important debate. It's a privilege to be speaking in this debate today on mental health. I must firstly declare a professional interest, having worked as a forensic and clinical psychologist over a period of 20 years in the NHS, specialising in mental health and at a consultant level for 10 of those years. I continue to maintain my skills and engagement in line with my professional registration requirements with the British Psychological Society and the Healthcare Professions Council. And earlier in the year, it was a privilege to contribute to the evidence taken by the Youth Select Committee in their inquiry into child and adolescent mental health services. I briefly wish to cover three areas in this debate today: adult mental health service and strategy, child and adolescent mental health services, and mental health services for veterans. Mental health is an extremely wide field, from major mental illness such as psychosis, depression and anxiety disorders, to trauma, eating and adjustment disorders. Developmental disorders are also sometimes included within the sphere of mental health, such as attention deficit hyperactivity disorder and autistic spectrum disorder, and I would very much welcome future debates in these areas, as I fear that we do not have time to do these very important areas justice today. It is reported by the British Psychological Society that 1 in 4 people in the UK will experience a diagnosable mental health problem, with mental health accounting for up to 23% of all ill health in the UK and being the largest single cause of disability. In Scotland, figures are currently 1 in 3. Mental disorders are strongly related to risk of suicide, and it should be known that high levels of comorbidity with substance disorder and physical health, ill health are prevalent. I'd like to start by stating that mental health services right across the UK are not the finished article wherever you go. We are continually striving towards improvement, and this should always be guided by patient need and by research underpinning most effective clinical practice. In terms of funding of mental health services, when I started practicing in the 1990s in Scotland, these very severely lagged behind other areas of NHS funding. This resulted in far too few practitioners and what seemed to be never-ending waiting lists for both patients and for clinicians to manage. At the start of my career at this time, patients routinely waited to see psychologists and mental health specialties for 6 to 12 months, and in some areas for over a year. This was clearly ineffectual, often meaning that problems were exacerbated over time and that mainly a medical model persisted. This is not what patients want, nor did it fit with best practice, where evidence indicates that patient recovery is improved with access to talking therapies alongside medical management. This is evidenced clearly within National Institute for Clinical Excellence guidelines. We have seen the heated targets adopted in Scotland and across the UK in 2014, meaning that patients should be seen from referral to assessment in 18 weeks. In Scotland in 2014, 81.6% of patients were seen in 18 weeks during the quarter, and the number of people seen in 2014 was 27% higher than the same quarter the previous year. Demand is increasing, which is actually a good thing. It means that we are starting to tackle stigma and that access is improving. Matched step care involving psychological therapies and practitioners at differing levels and depending upon clinical effectiveness of therapy type for differing disorders was rolled out within all boards within NHS Scotland, and NHS Education for Scotland took a primary role in workforce capacity modelling and training. Use of self-guided help has also been developed, and technological advances are important in terms of access for patients in this modern world and in relation to early prevention. Suicide rates have been brought down, and the target met of training high levels of frontline staff in suicide prevention and risk identification. Quality ambitions have also been developed as benchmarks in relation to person-centred, safe and effective care. There will, I fear, however, continue to be a dramatically increasing demand upon mental health services. Evidence suggests that recession increases mental health problems, including depression, suicidal behaviours and substance abuse. Unemployed individuals, particularly the long-term unemployed, have a higher risk of poor mental health compared with those in employment. Stress is now the most common cause of long-term sick leave in the UK, and the more debt an individual has, the more likely they are to suffer a mental health problem. A social and policy climate of austerity affecting the most vulnerable to a greater degree, I would argue, is a likely aggravator of mental ill health. I welcome pledges from both the Westminster and Scottish Government to increase spending significantly upon mental health. £100 million in Scotland. Mental health services, however, have not achieved parity with physical health services for decades since I started in the field, and we need to be clear that much more is needed to fill the gap. I would commend ministers and MPs to go out to mental health services and spend quality time with clinicians on the front line. Managerially produced statistics often include a multitude of issues, and it's only with this frontline insight that the true patient journey and daily clinical barriers can be identified. These are often excessive paperwork, repeated reviews and service changes that diminish morale. I come next to mental health issues in childhood. Mental health problems within childhood is an extremely serious problem. It can destroy educational potential at worst and impede it when problems are less severe. Difficulties must be assessed and recognised at an early stage. HEAT targets for CAMHS services were set at 18 weeks as of December 2014. NHS Scotland data suggests a significant reduction from 1,200 waits of over 26 weeks in 2008. 76.6% of CAMHS patients, that's child and adolescent mental health services patients, were seen in 18 weeks in the quarter ending June 2015, and the average wait was 9 weeks. There has been a 35% increase in demand in the past 2 years due to productive work completed on stigma and improving access, and 16 million has been invested in CAMHS workforce in Scotland since 2009, and it's at its highest ever level. 15 million further has been pledged to CAMHS services in Scotland to further improve waiting times. Widespread staff training has been undertaken in modalities such as cognitive behaviour therapy, family therapy, interpersonal therapy and specialist interventions such as for eating disorders, with a focus on seeing patients as close as to home as is possible. More progress is required across the UK and in Scotland to meet our 90% target. I must say that inpatient treatment for child and adolescents should be a very last resort. It takes children away from family and pathologises their difficulties. Best practice highlights intensive outreach approaches enabling children to be seen at home and treated within their natural environment, therefore maximising key family and peer supports. Children who need inpatient services suffer psychosis, intractable eating disorders, severe obsessive-compulsive disorder, and a variety of neurological conditions and neurodevelopmental disorders. There are currently 48 beds available in Scotland, and £8 million has been pledged and was pledged to build a unit for child and adolescents with mental health problems in Dundee this year. My own clinical experience suggests a lack of available beds in forensic child and adolescent mental health services and in learning disability child and adolescent mental health services, and constituents who have contacted me have also suggested that further work needs to be done in terms of improving access to specialist eating disorder inpatient care out with the private sector. Increases in the number of children presenting with self-harm and receiving brief overnight admission have been high. What I would say is that clinically this is quite a difficult decision. Often clinicians are faced with the issue of sending adolescents for a brief period of stay miles and miles from their home, and which makes it difficult for carers and parents to visit them or to admit them briefly overnight. Surely the maximum or optimum level of treatment would be to see and assess and make sure that children are safe and able to go home with the strongest possible package of care as quickly as possible. I would indeed.
I'm extremely grateful that she's willing to take an intervention. I'm greatly valuing her contribution as somebody with huge expertise. I get the feeling that there's a lot of medical expertise to come from behind the paper that she may be citing a lot of her speech from. I wonder if she, as the front bench spokesman for her party, could just explain to us whether she thinks the points made in the hoped for Amendment A, were valuable, and whether in the absence of that she still supports the motion as it stands, and how she would urge honourable members to vote today.
I don't support the motion in its reflection to Scottish Government care. As I've said, children who have mental health difficulties, clinicians have to make a very sensitive judgment regarding the length of potential stay, whether or not the problems are intractable, and they should be seen and admitted to a specialist unit, which can often be some miles from their own home, or actually in many of the cases we're seeing it's self-harm attempts which require psychiatric assessment, monitoring, overnight care and monitoring, and then a package of home intensive care to try to reduce another incidence of same. I hope that answers your question. Recommendations, however, I do feel have to be made in relation to CAMHS services. These include a wider appreciation of children's mental health beyond health itself, providing education and awareness in schools, and having access potentially to mental health clinicians in school settings and not just clinics. Just like diet and exercise, so should good mental health be normalised. These are all fundamental living skills that impact upon all aspects of functioning and deserve a more health and well-being slant rather than a pathologising label. Peer support. I would indeed.
I thank the Honourable Lady for giving way. Would she agree with me that to have these services in schools is actually invaluable and normalises the feelings of low self-esteem that many of these young children or young people are experiencing, and actually to have counsellors based in the school is very important for the mental health of these young people.
Many thanks, and thank you for that intervention. Yes, I think access to mental health within schools, mental health awareness and training, and particularly training for staff in schools so that they can pick up at a very early stage if someone is experiencing a mental health problem, and then try to access services at that very early stage is something that is definitely merited. So specialist training for teachers, I think, would be a positive step forward, so that they recognise the signs of mental distress in children. I think we also need to modernise our approaches to mental health for children and adolescents, embrace IT and social media methods of communicating, because that's the modern world and that's often where they communicate from. There's a project currently in Scotland called Safe Spot, which is an application website and school intervention to promote positive coping skills, safety planning and access to information about mental health services for very young people. The project is going very well, and the app is freely available on iTunes and Android stores. The Safe Spot app and website is going to be used within Greater Glasgow and Clyde Health Board, And also Dundee Health Board are looking at access to this app too. It was designed by a clinician, Dr. Fiona Mitchell, Specialist Registrar in Child and Adolescent Psychiatry, and I commend her for her innovative work in that regard. There remains a lack of empirical data regarding effective interventions for young people with what I would call comorbidity issues. That's mental health coupled with learning disability or substance use, and that certainly requires to be built upon. Looked after and accommodated children are also some of the most severely disadvantaged in terms of services and in terms of magnitude of difficulties, particularly those who also may have violence risk needs or self-harm needs. And I think further service provision for specialist groups and underpinning research will be crucial. Given that the weight of evidence for child and adolescent mental health services is in favour of psychological rather than pharmacological interventions for the majority of child mental health presentations, clear structures should be in place to support the delivery of effective evidence-based psychological therapies for children and adolescents. Those from socially disadvantaged backgrounds have always tended to have a poorer uptake of the child and adolescent mental health services, and I think an assertive outreach approach may be beneficial and required so that some of our most vulnerable and disadvantaged children and families do not slip through the net. Specialist service delivery in areas of developmental disorder such as autism, children in the criminal justice system and children with comorbidity, as mentioned, require to be thought through and planned so that these children and their families are able to access services without feeling that they are passed pillar to post. It's extremely difficult for families in particular to access early diagnosis of developmental disorder such as autistic spectrum disorder, which means that their needs can go unmet and their attainment may therefore diminish. In terms of mental health for veterans, just prior to closing, I continue to believe that this is an area that is underfunded across the UK and that those who have been willing to lay down their lives for their country should have consequent health, including mental health needs, prioritised. Minister agreed a few months ago during my adjournment debate that much more in this area would be done. I would now like to have a further statement to the effect of what more will be being done, particularly now as we are in a new conflict and the numbers of those in our armed services who witness or experience trauma will increase. What I would plead to the House as a clinician in mental health is that, to me, mental health services are beyond party politics. It's crucial that we tackle it meaningfully in a cross-party manner that brings about real continued progress on the ground for service users and staff, and that we share best practice across the UK and a what works philosophy. I welcome the announcement that there will be improved access to data. I think that also is crucial in terms of taking forward and ensuring best practice. And I think what I'd like to say in concluding is that I sense a real note of collegiateness across the House and a will to take this very important issue forward. I look forward to fully partaking in that, and my party certainly wishes to see mental health services continue to improve in Scotland, the UK and beyond.